Our project was an educational intervention to increase elder abuse reporting rates. I'm Mary Kate Fahey.
I'm Brianna Diefenbach.
I'm Sierra Nicholson.
I'm Francesca Vincent.
Elder abuse is an intentional act or failure to act that causes or creates a risk of harm to an older adult. The abuse can assume a variety of forms, including, but not limited to, emotional, financial, sexual, or physical abuse. Current statistics show that 10% of adults over age 60 suffer from some type of abuse in the home setting. 1 out of every 6 older adults experiences abuse in their community. Specific risk factors for elderly people include cognitive impairment and poor physical health. Due to cases often going unreported, these reported numbers are most likely an underestimate of the actual occurrences of abuse. When instances of abuse are not reported, the perpetrator can continue to abuse the victim without consequence. The victim may suffer both physical and emotional harm, which is inhumane. Reporting rates must increase to safeguard the health and overall well-being of the geriatric population. As researchers, we proposed a study investigating the following question. In older adults older than 65 years living at home or in long-term care facilities, will implementing an educational intervention for long-term care staff and families increase reporting rates of elder abuse?
For the search strategy, the Reeves Library was used to conduct our research for this project, particularly the Nursing Allied Health literature, otherwise known as CINAHL, was the main search engine utilized. Some of the limiters that were used when conducting our research included articles being published between 2004 and 2021, as well as the articles being in the English language. The keywords that were used for this search included elder abuse, education, nursing education, teaching methods, educational methods, signs and symptoms, clinical manifestations, mandatory reporting, gerontological care, incident reports, and patient abuse.
In order to answer our PCOT question, our group divided our research into 3 sections: recognition, reporting, and educational intervention. During the research process, it was found that survey results across varying healthcare disciplines were consistent, including PT, social work, EMT, dentistry, APS, CNAs, and student and licensed nurse.
In terms of recognition, there is a lack of standard protocol on how to identify elder abuse. Out of the 5 articles reviewed, the best tool to identify elder abuse was questionnaire surveys. The level of evidence of these articles included level 3, 4, 5, and 6. The limitations of this integrated review included a gap in the research, an 8-week time constraint, as well as only using 5 articles for the review. Due to this, more research needs to be done in order to provide higher levels of evidence to identify or create the best scales used when it comes to recognizing elder abuse.
The studies about the signs and symptoms of abuse show that more quantitative data is needed versus descriptive qualitative data gathered from surveys in the Level 5 studies. Self-perception makes the qualitative results less reliable. For example, an intervention that could be used would be providing an education program to a group of participants and tracking their reporting rates and the rates of signs and symptoms in their patients over the course of 3 years. This would provide stronger evidence that the educational intervention was effective versus a survey where a participant ranks their understanding of the signs and symptoms. Additionally, more concrete data could be tracked by creating scenarios that participants would be tested on whether or not they recognize the signs and symptoms of abuse. In a simulation, a patient could have signs such as bruising that would need to be recognized. This would be more concrete evidence of a person's ability to recognize abuse versus self-evaluation and self-perception. Furthermore, the ability to recognize certain keywords or behaviors from patients would give a more concrete evidence of a person's ability to recognize abuse versus their personal claims about ability to recognize abuse.
For reporting, it was found in all research articles that there were several barriers. These barriers include lack of knowledge on how and when to report abuse, ethical dilemmas of abiding by patients' wishes versus duty to report, differing views on what types of abuse should be reported, and not wanting to get involved in private family matters if the abuse is conducted by a family member. Several limitations were identified for this literature review. All articles found were level 6, which indicates there is a lack of strong evidence and more research needs to be done on reporting. There were inconsistencies within sample sizes, making them non-transferable to larger populations. Lastly, no studies were found focusing on general public reporting. There is an obvious need for an intervention in order for there to be a universal recognizing and reporting of elder abuse. However, it was found that there is little to no educational interventions in healthcare setting. Various modalities have been studied, but there is not one standard intervention and assessment set in place.
The best educational interventions were researched from my integrative review, and I found 5 articles with levels of evidence of 1, 2, 3, 4, and 6. There were various educational interventions reviewed, including face-to-face, game-based learning, PowerPoint simulation and debrief, and online learning. The use of PowerPoint simulation and debrief produced a positive impact on the knowledge and recognition of elder abuse among nursing students. It best improved the comprehension, skills, and disclosing of elder abuse among nursing students. It was beneficial to have a pre-brief prior to the simulation to help students understand the basis of what was going to be taught. The use of the simulation and debrief gave students an opportunity to implement what they learned in class. A limitation of the study was that the participants were tested immediately. Therefore, it may not produce high retention rates if retested 6 months or 12 months out. There is still a lack in healthcare workers and family members recognizing the signs and symptoms of elder abuse, including malnutrition, bruising, behavior changes, untreated injuries, and poor hygiene. There is not a standardized educational intervention set in place to provide in the healthcare setting to help increase reporting rates. With the lack of recognition and reporting, there are many elders being taken advantage of emotionally, financially, physically, and psychologically. Our research shows that educational interventions are still lacking. There are a variety of educational modalities that were presented, including face-to-face and online training, PowerPoint, simulation and debrief, and game-based learning. All of the different educational modalities produce a positive impact in increasing the knowledge and reporting rates among the participants. More research can be done to further expand and identify the best educational intervention for healthcare workers, which can help set institutional policy. When there is more research and a standardized practice set, healthcare workers will have a stronger knowledge in the recognition of elder abuse to report it. Overall, we would like to extend gratitude to Dr. Elise Kolencheko for her guidance and editorial assistance in this project.